Hello, I'm Candace Gutierrez, CEO of Integra Rehab.
I'm Glenna Gilliam, reimbursement nurse for Paramount Healthcare.
Welcome to Pdpm For Dummies, the first of 3 training modules for Paramount Healthcare. The goal for this training series is to prepare you for the changes coming up on October 1st, 2019. We have 3 series coming out, which is the one we're doing today, Pdpm For Dummies, which is an overview. We have an in-depth training session, Pdpm Boot Camp, and an on-site training session, Pdpm Sniper School. Pdpm For Dummies is to understand the basics of the patient-driven payment model.
I think there's a reason that they have Candace and I doing Pdpm For Dummies.
Very good, Glenna. And let's get started. Going from the rugs to the PDPM, one of the biggest things that I saw in the trainings with CMS was that they were not satisfied with the rug 4 model of being reimbursed for the amount of minutes therapy was providing versus the clinical characteristics of a patient. So they've been developing for years. This change has been coming. We've been seeing it through the different things that we've been asked for with the GGs, with the 24-hour care plans. There's been a lot of things coming to fruition to come up with this patient-driven payment model. So therapy minutes are no longer going to be the basis of payment. It's going to be functional outcomes, not only from therapy, but for nursing, documentation supporting that. Resident clinical characteristics determine the payment now.
For many years in nursing, for example, wound care, the facility didn't get paid anymore or reimbursed anymore for wound care, issuing a wound vac that requires close monitoring, extra equipment, special rentals that we have to achieve. We wouldn't get reimbursed anymore for that. Then we would put in a Band-Aid on a patient.
Right.
PDPM changes that.
Right. And also with therapy, group and concurrent therapy are now going to be capped at a combined 25% per discipline. And one of the things that CMS, wants to see is the group and concurrent come back, because it's also a psychosocial advantage for the patient, and they felt that was kind of taken away by just being driven by minutes. There will be 6 components required to establish per diem rates, and these rates are going to be established by a point system given to nursing, PT, OT, ST, non-therapy ancillaries, and a non-case mix that is the flat rate. What is going to comprise of nursing?
Nursing categories have been and currently are 44, and they're going to be taken down to 25 much more manageable categories that comprise all aspects of bedside nursing care.
Great. And PT and OT are going to have 16 clinical categories that they'll be able to fall into. And ST will have 12 categories that they'll fall into. And there's about 50 non-therapy ancillaries that will also allocate points to be given towards the reimbursement. So these categories, we're going to go in depth in the PDPM Boot Camp to train how the clinical categories are scored. Again, the non-case mix component covers things like room and board, capital cost, and overhead. It does not depend upon the resident characteristics. It's going to be based on basically rural or non-rural areas. It's a flat rate.
There's only two variables there.
Now we're going to cover the strategies for success under PDPM, which is going to cover ICD-10 code accuracy, section GG, PPS-MDS, therapy, skilled, and clinical documentation.
ICD-10 codes have always been very, very important, but now even more so with each code being assigned a number and the differences in how we put them in into our face sheets and into our diagnostic sheets. We're working on a smart sheet to help all of our nursing coordinators identify the more common diagnoses that we see coming into a skilled nursing facility.
Right. I think this sheet will help getting the accurate ICD-10 code so you get the appropriate points allocated.
Well, in the MDS, I and JI is strictly about diagnoses, and it's going to be imperative that we get those in on admission as quickly as possible. The goal is to have everything in within 48 hours. And the J section where we address components of falls and fractures and pain control is going to also be very important for the care of the patients and for reimbursement.
And as we have been illustrating throughout this training, the section GG is the collaboration between nursing and therapy will be essential for accurate GG function score, because that score is going to, again, add points to the overall reimbursement that is given to the facility based on the GGs. Again, we're going to go in depth of training on here with Pdpm boot camp of an actual sheet that's going to walk you through what score to provide for what services that you're seeing on a usual basis. Therapy's normally been doing the GGs since before October of last year. However, I know we've been getting requests from nursing to assist in that, but it's based on what the nurses are actually seeing, not what they're performing in therapy. So that's going to be very important for that training for them to be comfortable. Again, we're going to make another smart sheet for them to have like a decision tree of what the patient should fall under.
I think the GG section was real new to the nursing component, and they have to do it 3 consecutive days in a row from date of admission. And they were at first very uncomfortable with it and going to therapy and trying to rely on therapies, what therapy was seeing. But what nurses see and what therapy sees are 2 different things. I think they've kind of come to realize that nursing does their part, therapy does their part, and then we can marry the 2 together to come up with a more accurate description of the needs for the resident.
Right. And one of the things we're going to be working on as well is trying to blur that line between therapy and nursing so that we're working together to get those GGs more accurate on both ends. And, that's going to be part of the training for the patient-driven payment model, is making sure that the patient's involved in that training as well.
PDPM MDS assessment, there's only going to be 2 PDPM MDS assessments that are going to be required. The 5-day assessment that we're used to, the information is going to be gathered from the interdisciplinary team to capture all the optimal information for the resident and for reimbursement. The discharge assessment, which will include therapy minutes and GG, reported on the discharge assessment.
Yeah, well, that's one of the things that at the CMS training is that they are still going to be tracking the therapy minutes. Change in how therapy is being provided is just going to be categorized differently as far as on the MDS, but the minutes are still going to be tracked.
PDPM MDS is going to have an optional assessment. It's going to be called IPA for interim payment assessment. And there's no set schedule for that. That is going to be at the discretion of the interdisciplinary team, and whether the patient is improving or declining. It's going to be very important and for all aspects of the team to contribute. And when we do the PDPM meeting every morning, format's going to change from the PPS meeting that we know now, but still tracking days, tracking potential discharge dates, and tracking improvement or decline of any given resident.
Yes, and these improvement or declines would, possibly trigger an IPA to happen. And one of the things, again, that the CMS kept getting questions on was during the training was, well, what if this, what if that about a patient? And the answer stayed the same. It is optional. So you don't have to do it if it declines. You can do it if it increases your reimbursement. It's optional. They just kept saying optional. So that's something that I think would be very advantageous to be tracking, is any significant changes that are happening. This is where, the whole team can get involved during a morning meeting. If we see something changing, then we can maybe look at, okay, would an IPA be appropriate?
I just wanted to emphasize the 5-day MDS assessment and its importance. What hasn't changed is that we have between day 1 and day 8 to set that assessment, but it's going to be critical for any department that has a portion of the MDS to do or any of the UDA assessments to do, that they get them in a timely fashion, because this is the assessment. It is the only assessment that we have to set our revenue rate, and everything is going to be based off of it. So we cannot afford to be late. Everybody has to be working and together as an IDT to get this set or to make it successful.
I had an interesting story with the CMS training that I did. I guess the sections, if it was late, went into what, AAA days under current system. Under PDPM, it's going to go under a ZZZZZ code. And he says, the CMS coordinator basically said, you're going to get that default code because that means you were asleep at the wheel. You only had one time to do this assessment for 8 days. So, I emphasize with Glenna, get it in on time. I think we have the first 5 days of interdisciplinary collaboration to be able to make sure we have that set. With the clinical documentation, it's going to be important to make sure that everything is accurate with therapy, with nursing in the sections. One of the conditions of coverage is still the need for daily skilled services and that documentation. So under that, they also discuss the therapy services and the restorative nursing. This is where restorative nursing is going to come back into play. They've always been in play, but we've never been really reimbursed for it. PDPM is going to now allocate points. Restorative nursing is in the skilled services with the patient, with therapy involved as well. So I think this can also be very advantageous for a patient who is like non-weight bearing, and restorative therapy can go in there and do active or passive range of motion until they get the weight bearing status released to as warranted.
Some of the things that haven't changed in the Medicare PDPM module is that you still have to have a need for a skilled stay, such with therapy, with nursing. Those regulations are remaining the same, and this is a great opportunity for our restorative nursing program to come to light.
PDPM is going to require a lot of preparation, and we want to cover a few more areas that preparation I think would be advantageous for facilities to look at. And I know that Paramount is working with their EMR provider to make sure that they're getting selecting diagnoses in the right MDS category, identifying and tracking non-therapy ancillary conditions in the MDS, tracking cognitive and speech comorbidities. Also, documentation, the medical records, the pre-admission screenings are going to be very important. I mean, they are important now, but we're having to look at what we can capture maybe 90 days before the admission, whether it be a surgery, whether it be other treatments that they got that we can take credit for supporting their need for skilled nursing.
Yeah, this is a part that's really kind of exciting because we do not have to rely solely on the diagnoses of what took the patient to the ER and ultimately to have an inpatient acute care stay. We can also look at chronic conditions that they have, like CVAs, diabetes, and such.
Mm-hmm. That's great. The trainings on the ICD-10 codes and the GG trainings that are going to be done in the PDPM boot camp and the clinical competencies are going to put all the therapists and nurses on to require their clinical practices to be at the top of their license. And this is one thing that excites CMS, is that this way that they feel that the reimbursement is going to be allocated for the patient outcomes versus the quantity of therapy given to the patients. So again, for SNFs to succeed under this is also going to help them succeed in their QRS scores and their 5-star ratings. And those are going to be something, again, we're going to be going over in our further trainings of how they all marry each other so that we get not only a great reimbursement, but we also get that rewarded in your QRS scores and hopefully in your 5-star ratings. We're going to reemphasize what does not change under PDPM, because this is important when you bring in a skilled patient, that we make sure that we're checking the 3 midnight stays, the medical necessity that the facility is able to be able to provide services to the patient under nursing or therapy skilled needs. I think they feel that the non-therapy ancillaries will be looked at, but if it still doesn't have the skilled need of therapy or nursing, they may have that non-therapy ancillary, but it's still not skillable. So that's real important that CMS wanted everybody to know, that it didn't open gates of what is skilled. That doesn't change. You just get points for having those non-therapy ancillaries or nursing services that weren't getting reimbursed in the past. To recap, alignment of nursing and therapy clinical documentation and coding will be critical to support the skilled clinical care provided and reimbursed. One of the things, Glenna, that I think that is exciting about this is it focuses on the patient and not on the quantity of therapy provided. And I think, instead of attempting to calculate the minutes and putting them in a rug level, we can really sit down with the patient and say, okay, what is your need? And if therapy is not the top provider for this patient, then nursing gets in, and therapy can assist in the back until maybe they get stronger or more stabilized, and then therapy can get in. I think, obviously it's going to open the door for, higher acuity patients for the facilities. But I think if we, again, bring the therapist and the nurses up to their license of care, I think, it's going to be a good thing.
Yeah, I do too. I think for several years now we've seen where skilled nursing facilities have accepted higher acuity patients, and at the beginning we were a little bit leery of that with the trachs and thinking about TPM or TPN, and now we're thinking of NG tubes, more advanced wound care. We're not sending patients out to wound care centers like we used to, treating them more in-house. So we just have to get on board with that. That's where our education and training is for, and now we get the opportunity to use it. I think it's a real good opportunity for social worker and ST to work together for cognition and to work for ultimately planning a discharge for the patient in a safe environment, whether it be to go to an assisted living or back home or into a long-term care facility and explore what their options are.
Right. And one of the things that's going to be, it's not only getting the interdisciplinary team, within the facility, it's an interdisciplinary team within the community, being from the hospital to home. We're that stepping stone. So going from the hospital, making sure that they're educated with PDPM of what we're requiring upon admission and the documentation that we need. I've talked to many of the case managers in the hospitals, and they're excited about this collaboration because they're hoping that, us doing the right thing and partnering with good home health agencies, that we can keep the patient from that 30-day readmission. And that's one of the things that I think we want to be working on. I know Paramount's an advocator of making sure that we partner with home health agencies that will collaborate and even come to the care plan meetings before discharge. We have a great model here in El Paso doing that, to where the patient goes home, and if the patient is not quite ready, they can come back to the nursing facility before they go the 30 days, back to the hospital. So there's, working. I think one of the things we did leave off here that I want to emphasize, it'll be something that we're training them on individually, is the medical director. The medical director is going to be a very key player in this PDPM, and making sure that we need the diagnoses that we, if we don't see that, we get, and making sure that they understand the PDPM model as well, which we are doing training for our medical directors and medical staff that is not, part of the nursing staff.
Yeah, it will be a lot of training for all of our departments, and like you said, including the physicians that come into the facilities. And I think a very strong misconception early on with PDPM is that we would need less therapists or we would need less MDS coordinators, and that really is simply not true, because if we start focusing on that type of reduction, we're going to miss our reimbursement, we're going to miss assessments, we're going to miss opportunities for the residents.
Right. One of the things that CMS was illustrating too is that wasn't their intention at all in coming up with this payment model. One of the things would be the MDS coordinator would be more out with the patient care instead of doing assessments every 7 days or 14 days or 30 days.
Yeah.
And the therapist would be actually doing the one-on-one training and not counting the minutes, seeing what their clinical outcomes were going to be, which are, I think going to be advantageous or, for all parties involved.
I think back in the day when I did I was MDS coordinator at a facility, and I'd come sit in your gym and watch the therapists interact with the patients and do eyes-on observations. I think I got in their way a little bit, but didn't mean to.
No, but that's going to be the way it is so that you can get an accurate assessment of the patient for their outcome status.
Mm-hmm. Exactly. So it's exciting. Change is not always bad. In this case, I think it's real good. It's good for our staff, and it's good for the residents.
Right. The one thing that doesn't change is change. I heard that before as well. And so I think if we just embrace it with knowing that there's a lot of opportunities in this change for not only the residents but also the staff, I think we will successfully be able to do this transition with little bumps in the road. And we have a frequently asked questions section. If you have any questions regarding what we covered, or you feel that you weren't clear on, please, you can set your questions to integrarehabinc.com/PDPM FAQ. And if I can't answer them or Glenna can't answer them, we will go ahead and submit it to CMS, who gave us a contact there to be able to answer any questions. And if you have any questions or recommendations for the what you want to see on the boot camp PDPM training, please submit those as well. And just to recap what the boot camp PDPM is going to cover is the training for the GGs for nursing and therapy, and that's going to be pretty significant hands-on training. And then clinical categories for each PT, OT, ST, and nursing, and how those points are allocated. The non-therapy classifications, where we can also obtain some further points towards the reimbursement. I think that concludes our training session.
Okay, thank you. We'll see you at boot camp.
Thank you.